Hi everyone, this is Mrs. Campagna again, and today we're going to talk about the metabolic and endocrine section that's coming up for your next test. Main focus of this is going to be diabetes. So let's take a look at this. Okay, first of all, let's talk about glucose regulation in your body. There's a whole biofeedback system here that helps with glucose regulation. Okay, so let's start here. We have a high blood sugar in our body, okay? Insulin gets released from the pancreas, okay? And then that sends insulin to the cells and to the liver. The insulin in the liver causes glucose to store as glycogen, and then it causes the tissue cells to take in the glucose in the bloodstream, so therefore your blood sugar gets lowered. Okay, and then the glucose storing to glycogen also lowers the sugar. Now, if you have a low blood sugar in your body, well, that promotes your pancreas to then produce glucagon, okay, and the glucagon then stimulates the liver to bring the glucose out of storage and change the glycogen to glucose. And then that releases it into the bloodstream and raises the blood sugar. So that's the basic glucose regulation in the body. The pancreas, as you see, the pancreas and the liver are the big organs that deal with glucose regulation. Let's talk about the pancreas. So the pancreas has a couple jobs. It deals with the blood sugar regulation, but then it also deals with digestion of foods as well. But for the sake of this unit, we're just going to talk about blood sugar regulation. So the cells in the pancreas are called the islets of Langerhans. And there's two different types, two different sections of cells there. There's the alpha cells and the beta cells. So the alpha cells in the islets produce glucagon, okay? Now the glucagon then stimulates the liver to release glucose. So if your sugar's low, the glucagon will send a signal to the liver to release glucose into the bloodstream. Your beta cells of your islets of Langerhans in your pancreas produce two things. Insulin, we already know what insulin does. The other thing it releases is something called amylin, A-M-Y-L-I-N, amylin, okay? Amylin stimulates your stomach to slow gastric emptying. So how does that help blood sugar regulation? Here's how. When you eat, amylin gets released from your pancreas, tells your stomach and your duodenum to slow down so the stomach doesn't empty into the duodenum as quickly as it usually would. What this does then is this helps you feel fuller if you're a diabetic, and then it also will decrease blood sugar spikes after meals. So if you have a whole bunch of food getting dumped into the intestines, well, that's going to absorb the glucose faster. But if you slow down the rate at which that food's getting dumped to the intestines, then the blood sugar just gets released in little increments into the bloodstream versus a whole bunch of it getting dumped in at once. So, the next thing we're going to talk about is the pathophysiology of diabetes and what really happens. So what happens is your insulin, something's happening with the insulin. Either it's not there or it's not able to do its job, okay? So what happens in the body when it doesn't have the insulin, okay? When it can't get the insulin or doesn't have the insulin, well, it has to figure out a different way to make energy and to get its sugar because it can't get the glucose that it needs because the insulin's not there to give it to it, okay? So a couple ways is the glycogen in the liver can get changed to glucose and release some that way. You also have gluconeogenesis, which is forming glucose from protein, like your muscles. Then you have the lipolysis, which is the fats breaking down, okay? And when your fats break down to create energy, they can release fatty acids. and that in turn causes changes into a ketone body, which can lead to ketoacidosis. Okay, if you guys want a little bit further information into that, Khan Academy Medicine on YouTube has great videos and illustrations explaining diabetes, tons of videos. So if you guys need more in-depth explanation about diabetes and its complications and things, please go to Khan Academy Medicine and on YouTube. Okay, let's talk about the different types of diabetes. We got type 1 and type 2. Type 1 is an autoimmune disease. Okay, so with type 1 diabetes, immune cells are attacking the beta cells in the pancreas. Okay, because for some reason it sees it as an enemy and it's foreign, and so your immune cells attack it, destroying the beta cells. Well, if the beta cells are destroyed or injured, they can't produce the insulin. And if you don't produce insulin, then you don't get the glucose ushered into the cells, and then the cells don't have the sugar that they need. So what do type 1 diabetics look like? Well, they're going to be hungry, they're going to be thirsty, and they're going to pee a lot. But why? Actually, the 3 P's, the polyuria, polydipsia, and polyphagia, can happen in type 1 or type 2. Okay? But here's why. Polyuria. So why do diabetics that have a high sugar, why do they pee a lot? Well, the high glucose level in the blood causes fluid to shift from cells into the bloodstream. Okay, so if you remember, if you watch the video on the fluid and electrolyte balances, we talked about how, okay, we have our bloodstream here, and then we have our little cell over here. Okay, so if you have a lot of glucose, these will be our glucoses, floating around in the blood, and you have a higher concentration of glucose in the blood here. So what this does is it almost creates like a hypertonic type situation. You have higher particles than fluid in your blood, so it makes your blood seem more concentrated to the cells. So then what do the cells do? The cells kick out water to the bloodstream to try to even things out. Okay? So the cells kick out water to the bloodstream to try to even things out because they see this as concentrated blood because there's so many particles in it. So it just kicks it out to even it out, the whole osmosis thing. And when that happens, then now you've got a lot of extra fluid floating in your bloodstream. Gets to your kidneys, and your kidneys say, hey, we got extra fluid, and it kicks it out. So you have polyuria. You're peeing a lot. Okay, polydipsia. So with polydipsia, you have the fluid shift, okay? So now you have the fluid that left the cell, and now it's in the bloodstream. Well, then your cells are like, hey, I'm running out of fluid here. I lost some fluid. I'm thirsty. So then that causes you to become thirsty. And plus you're peeing a lot as well, so you start to get thirsty. And then last, we've got polyphagia. So the reason for this is because if you have the glucose floating around in here, but there's no insulin to get this glucose into the cell, these cells are starving, they're hungry. So that sends a signal to your body, I need sugar. And your brain says, okay, you need sugar, I'll eat, so that we can get more sugar into the bloodstream. Not knowing that the problem isn't that there's no sugar in the bloodstream, the problem is the sugar from the bloodstream can't get into the cell because there's no insulin to take it there. Okay, in these patients, type 1 patients, they're usually pretty thin, type 1 diabetics. They're tired because they're not getting the energy that they need and the sugar that they need in their cells. Frequency of infections. If you've got lots of sugar floating around your blood, then bacteria love sugar, and you get frequency of infections. Rapid onset. Yes, this can happen all of a sudden. You realize you're a diabetic one day when you go into DKA. Insulin dependent. Diabetes type 1 patients are insulin dependent because they have no insulin, because their beta cells can't produce it because they're being destroyed. Familial tendency? Yes. Autoimmune disease, family, it does run in families. Peak incidence from 10 to 15 years, so that's usually when patients start discovering that they have type 1 diabetes, is in their youth. Okay, let's talk about the difference between type 1 and type 2. So type 1 up here, we have, here's a healthy one, okay? So we have healthy pancreas giving off the insulin, taking the little sugar molecule and sticking it in the cell, right? Into this insulin receptor into the cell. Type 1, no insulin, the sugar can't get in the cell. Type 2, got plenty of insulin most of the time. Sometimes there's an insulin production problem as well. But the main difference between type 1 and type 2 is a lot of times in type 2 we have a problem with the little receptors on the cells not letting the not responding to the insulin and letting the glucose in. Okay? Type 2 diabetes. So if you see here, there's a lot of, you get a history of high blood pressure, sedentary lifestyle, obesity, okay, older patients. These are the patients that are going to develop type 2 diabetes. It's usually after age 50. It can still run in the family. These guys are also going to be fatigued with low energy because their cells aren't getting the energy that they need. Okay, you're going to get these guys have recurrent infections too because they've still got high sugar floating around their bloodstream, and bacteria love sugar. They get the polyuria and polydipsia as well because of the high sugar. You still get the fluid shift with the high sugar. So if you see, a lot of the symptoms are the same. The big difference is the mechanism in the body that's causing the problem, number one, and number two, a lot of times how you treat is different. Okay. Here's some, just a picture of it. There's several different therapies you can give for type 2 diabetes and different organs that they work on and how they work. So here's a visual. Again, Khan Academy Medicine also has videos on YouTube about drug therapy for diabetics as well. Okay, insulins. So the biggest thing I want you to get from this slide is the different levels. Which one's the slowest, or not the slowest, but which one is, lasts all day, and then how fast the peaks and onsets and things are. Now, the specific peak and onset times differ slightly from your book. Please go with the ones that are in your book. You can even take this slide and print it out and cross out and put the correct times in there. But please use the peak and onset times from your book. The biggest thing to remember about this is your Lantus is one that doesn't have a peak. It lasts all day. That's your one here. And then your fastest working one is your Rapid, okay? And your Rapid starts in 15 to 30 minutes, so that's real fast. So the thing you got to remember with the rapid insulin, you don't give that until the patient is ready to eat right now. So let's talk a little bit more about type 2 diabetes. Here we have, it says a fasting blood sugar of greater than 126. In the book it says greater than 100, so you can cross that out there and put greater than 100. Also, we have to worry, we monitor something called a hemoglobin A1C, or a glycosylated hemoglobin. And what the glycosylated hemoglobin does is it tells us, has your blood sugar been high for an extended period of time? So a serum glucose level tells you only that when that person when that person got their blood taken, at that snapshot moment in time was their sugar elevated. Okay, that's all a blood glucose level can tell us. A hemoglobin A1C or a glycosylated hemoglobin, same test, that one tells us, has their sugar been elevated for a longer period of time? Okay, so usually when the hemoglobin A1C is greater than 6, that tends us to say there's a problem here. Type 2 diabetics, their hemoglobin A1C can be usually 5.5 to 6 is when they're diagnosed, and then it can be higher than that even. So how do we treat type 2 diabetes? Well, a lot of times if we just change their lifestyle and their habits, that the cells actually start responding to insulin better again. So if you encourage them to exercise, get them an exercise plan, a weight loss plan, change their diet to a low carbohydrate diet, stress management, okay? And then when those don't work, then you start doing medications, okay? That's when you can give the sulfonylureas and the biguanides and things like that. And then, if those don't work, more than 3 of them don't work, then we're going to give insulin on top of that to help with whatever the oral meds are not covering. Okay, now let's talk about sick day rules. Okay, when your patient is sick, your diabetic patient is sick, they need to remember that they've got to check their blood sugar every 4 hours. Illnesses can raise and lower blood sugars. It can make them very erratic, especially in somebody who's a brittle diabetic. So we got to make sure we take care of this. Got to encourage them to check their sugar every 4 hours. Also remind them they need to continue taking their insulin and medications as ordered. Because a lot of patients are like, well, I'm not eating, so I'm not going to take them. But at the same time, you know, illness can raise your sugar. In that same regard, we have to remind them that even when they're not feeling good, they still have to eat. Okay, they have to eat their meals at regular times, and they need to keep drinking their fluids. Okay, 8 to 12 ounces an hour. If your blood sugar's high, choose sugar-free. If your blood sugar's low, choose sugary. Okay, so make sure you remind them of that. And then also they need to be checking their ketones if their blood sugar is greater than 240. Also, it's probably a good idea, tell your patient it's a good idea for them to call their doctor and let them know that they're ill, so that their doctor can keep track of things and give them any advice. Okay, and now let's talk about diabetes complications. So, first of all, we'll go around the little wheel here and explain some things. There's 2 different types of complications. There's macrovascular and microvascular complications of diabetes. So the macrovascular are going to be things like stroke, heart attack, peripheral vascular disease. And a lot of these are caused because of the lifestyle and the diet habits of the patients who develop diabetes. Okay, there are also some correlations with hyperglycemia that also cause cardiovascular issues. But a lot of it is just comorbidities and the other problems that diabetics usually have. So now we can talk about retinopathy. So with diabetic retinopathy, you get blood vessel blockage from high glucose, big glucose molecules and things like that. So that leads to a leakage, and it also leads to hypoxia because the vessels are blocked. So if vessels are blocked, they're going to start leaking, and they're going to whatever is past the vessels that's not getting the oxygen that it needs. There's 2 different types of retinopathy. There's non-proliferative, that develops slowly and usually doesn't cause blindness. And then you have the proliferative. So what happens with the proliferative is that you grow new vessels around the blockages to try to compensate. Okay, so you have a roadblock and your body makes detours around it. But the problem is these detours are weak. These new vessels that grow are weak and they bleed easily, and they lead to hemorrhage and blindness. So non-proliferative retinopathy develop slowly, usually don't become blind from that. The proliferative, where you grow the extra weak blood vessels, that causes hemorrhage and blindness. Cataracts and glaucoma are also linked to diabetes. Diabetic foot, that is things like hammer toe and claw foot. That's due to there's alterations in the motor function in the foot muscles. Diabetic nephropathy. Okay, so hypertension and high blood sugar leads to increased blood flow through the glomeruli. Okay? Increased blood flow through the glomeruli has increased pressure, and it slowly damages the glomeruli over time and causes them to malfunction. You'll see a lot of the diabetics with renal failure. And then we have peripheral neuropathy, and this is just caused by nerve cell hypoxia because of the hyperglycemia, causes altered nerve signals. And these are the patients that have the pins and needles and the tingling and everything like that. So let's take a look at this guy over here. So we talked about stroke. This is a diabetic guy. This guy over here, this half of the guy is a controlled diabetic, takes his meds, is compliant with his diet, he exercises, he stays as healthy as he can. This guy over here doesn't take his meds. He drinks Coca-Cola and eats tons of carbs, mac and cheese every night for dinner. And this is what he looks like. Okay? He's had a stroke. He's blind because of the proliferative retinopathy. He's had a heart attack. His kidneys have shut down. He has impotence, and that is a vascular complication of diabetes, and amputation because of a vascular complication. Okay, here are some videos on YouTube. Again, I said Khan Academy Medicine. Here are some specific videos if you want a little bit more in-depth explanation about diabetes complications. These videos explain them very well. Now we talk about hypoglycemia. Okay, so hypoglycemia is low blood sugar. Everything else we talked about was high. Now we're going to talk about low. So what causes hypoglycemia? Well, three things here. Insufficient food. You don't take in as much food as you should. Excess insulin, okay, or excess exercise. So if you exercise, you may use up more sugar than you would usually, and so your body hasn't regulated it and you drop your blood sugar. Or you give yourself too much insulin and don't eat enough, you're going to drop blood sugar as well. This can happen pretty quickly. You can drop a sugar within 1 to 3 hours. It can happen pretty fast. How do you fix them? You give them blood sugar. But let's look at this, not blood sugar, you give them sugar. But let's look at some signs and symptoms here. They're anxious, they're sweaty, they're hungry, they're confused. Blurred or double vision, shaky, irritable, clammy. Sometimes they're unconscious. Depends on how low their sugar is. Okay? This can develop into a life-threatening situation. These guys can go into a coma and die if their sugar drops too low. So this is a much more urgent and emergent situation than hyperglycemia is. So how do we fix these guys? Okay, you can give them IM or sub-Q glucagon, although you have to be careful with this because that can cause vomiting. So that glucagon will then stimulate the liver to release some glucose for you. You can also, if the patient's awake but they're just anxious and sweaty and their sugar's a little low, you can feed them. You can give them some graham crackers, okay? Something simple like that. And then you're going to give them, if it's an emergent situation where their sugar's real low and you can't really get them to wake up real good, you can give them IV dextrose, 50% dextrose IV. Okay, you have to be careful with that medication though because check your IV site before you give it because you want to make sure you have a good IV site. This can cause tissue damage if it leaks out into an infiltrated IV site. Okay, lastly, we're going to talk about the Somogyi effect and the dawn phenomenon. Okay, so with the Somogyi effect, this is where your insulin peaks at night, and when your insulin peaks, well, then you get almost like a hypoglycemia while you're sleeping, and your body, remember your body's always trying to maintain homeostasis, so your body actually mobilizes glucose, kicking it out of the liver and putting it into the bloodstream to try to fix the problem, and it actually overcompensates. So when you wake up in the morning, your sugar's high. So we have to be real careful with that when we give people bedtime insulin. Okay, so if people are waking up with morning headaches and night sweats, or they have ketones in their urine if you do a UA in the morning, this could be a Somogyi effect going on here. And you may need to reduce the amount of insulin you're giving that patient at night, because it's making their blood sugar bottom out in the middle of the night, and then the body reacts by putting more sugar in the bloodstream. Okay? Now, the difference between that and the dawn phenomenon is that the growth hormone that we have that gets released during the night, it decreases the peripheral glucose uptake. So the amount of glucose that's being used up by your peripheral vessels in your peripheral cells is not being used as much as it was before during the night. So this causes it more excess floating around in your bloodstream, and by morning you have a high blood sugar. Okay, so the difference between the two is the Somogyi effect has to do with your body's reaction to the insulin that you gave it before bedtime, where the dawn phenomenon is just where your body is not using the amount of glucose that it usually was because of a growth hormone at nighttime that your body releases. And then here is a graph to show you a little bit more of the difference between the two. So you can see the dawn phenomenon is you go to bed and your sugar goes down just a little bit, but then you stop using so much sugar, so it starts floating around in your bloodstream, and then it gets high in the morning. Where the Somogyi effect is your insulin drops your sugar and your body goes, whoa, we need some sugar, kick out some out of the liver into the bloodstream, kicks out too much, and then you end up going high. So that concludes my review of diabetes, and take a few minutes to answer the practice questions, and then I will go over them. Okay, let's go over these practice questions. Question number 1. Which explanation best assists a client in differentiating between type 1 and type 2 diabetes? Okay, so which of the following statements is the most true about the difference between the two? Okay? Number 1, most clients with type 1 are born with it. True, but some with type 2 are born too, have a family tendency to have it. People with type 1 diabetes are often obese. No, they're usually thin. The type 2 are obese. Those with type 2 diabetes make insulin, but in inadequate amounts. And this is true. Sometimes we have trouble with the beta cells making the insulin. And then people with type 2 diabetes do not develop typical diabetic complications. False. They both do, type 1 and type 2. So the answer is C. Number 2, the nurse receives a report on a 52-year-old client with type 2 diabetes. So here's your report. His lungs are clear. His right great toe is mottled. Do we remember what mottled means? Mottled means that there's not enough oxygen or blood getting to that area. Okay? There's usually some vasoconstriction and some other things going on. The client states he wears eyeglasses to read. Glucose is 179, that's elevated. Hemoglobin A1C is 6.9, that's high, but we expect it to be because he's a type 2 diabetic. He gets 8 units of regular if his blood glucose is 250 to 275, which it's not, and regular 10 if it's 275 to 300, which it's not. So let's take a look and see what we have to choose from. Which complication of diabetes does the nurse report to the provider? So This is saying which one of these complications that your patient has is the most important one that you're going to call the doctor for. Okay? Poor glucose control. He's 179. It's not out of whack, and we were already given orders to keep his sugar under control. Visual changes. No, he's wearing glasses, so this is a chronic thing. It's not an acute thing. Respiratory distress. If he were in distress, that would be the answer. But look at the only thing you have to go by for respiratory assessment. His lungs are clear. So it didn't tell us he was in any kind of distress. So we're not going to go with that one. Decreased peripheral perfusion. Correct, because his right great toe is mottled. If you don't fix that situation or let the doctor know about it, he could lose his toe. So we have to make sure we let the doctor know about that situation. Number 3, a client with type 1 diabetes is getting regular insulin at 7 a.m. The client should be monitored for hypoglycemia at which time? So what's this question asking you? When does regular insulin peak? Okay, that's what it's asking you. Does it peak in a half an hour? No, that's your rapid insulin. Can it peak in 4 hours? Yes, it can. Can it peak in that would be 7 hours? No. And does it peak in 12 and a half hours? No. So the only option we really have here is B, 11 a.m., 4 hours. A client newly diagnosed with diabetes is not ready or willing to learn diabetes control during the hospital stay. So which information is the priority for the nurse to teach the client and the client's family? So the patient doesn't want to learn all the ins and outs about diabetes. He doesn't want to learn about diet or exercise or insulin or any of that stuff. So if there's one thing you need to teach this patient that can save his life, what do you teach him? Okay, so we got to think about that. Which one of these answers can be the most life-threatening? Okay, letter A, causes and treatment of hyperglycemia. Can it be life-threatening? It has to be super high to really cause a problem, which doesn't happen very often. Letter B, causes and treatment of hypoglycemia. Yes, remember I said hypoglycemia, if it drops too low, can lead to coma and death. Okay? Dietary control, he's not going to listen to you for dietary control. He's not ready for all of that in-depth information. Insulin administration, he's not interested in learning how to give himself insulin either. So the most life-threatening one is going to be the hypoglycemia. That's the one you need to teach him. Remember the word, it says priority, and remember what I said about priority: airway, breathing, circulation, safety. The one that's going to keep the patient the safest is going to be letting him know what to look for hypoglycemia. Number 5, the nurse is providing discharge teaching to a client with diabetes about injury prevention for peripheral neuropathy. Which statement by the client indicates need for further teaching? So that means which one of these is false? Okay? Injury due to peripheral neuropathy. Okay? So let's look at these. I can break in my shoes by wearing them all day. Okay, if you can't feel your feet that well, then you don't want to be wearing shoes that are brand new all day, because you can get blisters and sores and not even know it. So that's an option. I need to monitor my feet daily for blisters or skin breaks. That's true. I should never go barefoot. True. I should quit smoking. True. So the answer is A. He cannot wear his shoes all day. Okay, let's move on to number 6 here. The nurse is providing discharge teaching to a client with newly diagnosed diabetes. Which statement by the client indicates a correct understanding about the need to wear a medic alert bracelet? Okay, so which one of these does he need to have a bracelet on to tell healthcare workers that come to rescue him? What do we need to tell these people? Okay, so which one of these demonstrates correct understanding? So which one is the true answer? A, if I become hyperglycemic, it is a medical emergency. Not usually. B, If I become hypoglycemic, I could become unconscious. True. C. Medical personnel may need confirmation of my insurance. They usually figure that out at the hospital, not when they're in the field with you. Or D. I may need to be admitted to the hospital suddenly. Not a reason to have a bracelet. Okay, so the most important reason that a patient would be wearing a MedAlert bracelet is because if he becomes unconscious, they need to be able to know some things about him. 7. The nurse is teaching a client about the manifestations and emergency treatment of hypoglycemia. In assessing the client's knowledge, the nurse asks the client what he or she should do if feeling hungry or shaky. Which response by the client indicates a correct understanding of hypoglycemia management? So which one of the following is a correct statement? I should drink a glass of water. That's not going to manage your hypoglycemia. I should eat 3 graham crackers. Yes, that will help with hypoglycemia. I should give myself 1 milligram of glucagon. You're more likely going to do the graham crackers first. That's your first line of defense. And then I should sit down and rest. That's not going to help your hypoglycemia either, really. If feeling hungry and shaky, he should just eat some graham crackers. So the answer is B. 8. A client has been diagnosed with diabetes. Which factor is the most important for the nurse to assess in the client before providing instruction about the disease and its management? Okay, so you're getting ready to teach, okay? So think about teaching plans. You guys done teaching plans yet? This is like teaching plans. Which is the most important factor to assess on somebody before you teach them? Lifestyle, education and literacy level, sexual orientation, or current energy level? Education and literacy is important because that's going to change the way you teach. Number 9, a client expresses fear and anxiety over the life changes associated with diabetes, stating, I'm scared if I can't do it all, and I'll get sick and be a burden on my family. What's the nurse's best response? Okay, so when you are trying to do therapeutic communication with somebody and you're trying to talk to the patient, you want to pick the answer that gets the patient to talk to you, that get the patient to elaborate on their feelings. Okay, so let's see which one of these would get the patient to elaborate. It is overwhelming, isn't it? No, that's a yes/no question. Let's see how much you can learn today so you're less nervous. Now, you don't teach somebody when they're scared. 3, let's tackle it piece by piece. What's most scary to you? Okay, there's an open-ended question. And then other people do it just fine. No, you're blowing the patient off. So the answer is C. Number 11, a client recently admitted with new onset type 2 diabetes is going to be discharged with a self-monitoring blood glucose machine. When is the best time for the nurse to explain to the client proper use of the machine? So let's look at these answers. Should we explain it to him the day he's supposed to leave? Should we explain it to him when he gets there, when the client states he's ready, or while performing the test in the hospital? So the correct answer is going to be while performing the test, so that you can show him how to do it. And you actually can do it. You're actually going to prick his finger and put the blood on, and you can show him how to do it, and then maybe the next time he can do it so that he learns how to do it. It's going to work much better than just standing there explaining it to him. Number 12, which is the best referral that a nurse can suggest to a client who has been newly diagnosed with diabetes? Well, out of all of these, I would probably pick the answer that has diabetes in it, the American Diabetes Association. They're going to have the most information for the patient, resources, pamphlets, information, teaching classes, diabetes education classes, things like that, diet choices. They're going to have it all for them. Number 13, a diabetic client has a glycosylated hemoglobin, or hemoglobin A1C, of 9.4. What does the nurse say to the client regarding this finding? Well, first of all, we got to know, what does a glycosylated hemoglobin of 9.4 tell you? It tells you that their sugar has been quite high for a while. So what do we want to know about this patient? Or what do we say to this patient? Keep up the good work. No, it's too high. His sugar's too high. This is not good at all. Well, no, you're kind of degrading the patient by saying that, kind of, scolding them a little bit. They don't like that either. Then you can ask them, what are you doing differently? Okay? Find out. Maybe they changed their diet, or who knows? Maybe they had a death in the family and they're stress eating. Who knows? We need to find out what's going on with the patient, why their A1C is up. And then you need more insulin. Well, that's not your call to make. So the best one would be get the patient to talk to you to figure out what's going on, figure out the problem. So the answer is, what are you doing differently? Number 14. The nurse is teaching a client with diabetes about proper foot care. Which statement by the client indicates that teaching was effective? That means we're going to pick the true answer. Okay? Number 1. I should go barefoot in my house so that my feet are exposed to air. No, diabetic patients should not go barefoot. Number 2. I must inspect my shoes for foreign objects before putting them on. Yes, we always do that because you don't want to have a Lego or something in your shoe and then put it on and not be able to feel it. Number 3, or S, I guess. I will soak my feet in warm water to soften calluses before trying to remove them. No, you're not going to have your patient remove any calluses or cut their nails and stuff like that. That needs to be done by a podiatrist. And also, you don't want them softening their feet because then their skin could be penetrated more easily. And then letter T, I must wear canvas shoes as much as possible to decrease pressure on my feet. No. So the correct answer is I must inspect my shoes for foreign objects before putting them on. Now say here that you didn't know about canvas shoes, that they were super, there was a problem with your the canvas shoes. So you're like, oh, I don't know, do canvas shoes help or hurt diabetics' feet? Okay, so you're stuck between that one and inspecting the shoes for foreign objects. Well, here's what I say. You know that the patient should absolutely inspect their shoes for foreign objects before putting them on. You know that that statement is 100% true. So pick that one. Because when you have teaching was effective, you're picking the 100% true answer. Letter R is the 100% true answer there. So if you're hemming and hawing between two and you know one's absolutely true, then pick that one. And last, the nurse caring for our diabetic clients has all of these activities to perform. Which is appropriate to delegate to a UAP? So this would be somebody like a CNA. Perform hourly blood glucose checks on a client with hyperglycemia. Verify the infusion rate on a continuous infusion insulin pump. Monitor a client with blood glucose of 68 for tremors and irritability. Check on a client who's reporting palpitations and anxiety. Okay, so the only thing that UAPs can do is record and report. Okay, so they can't assess and they can't intervene. So verifying the infusion rate, that's really going to be an intervention or an assessment. You're verifying, so I guess that's more of an assessment. You're assessing the infusion rate on a pump. Monitoring a client for tremors and irritability, that's an assessment. Checking on a client who's reporting palpitations and anxiety, that's an assessment. So the only one that is a record and report is letter A, performing hourly glucose checks on a patient with hyperglycemia. So that concludes the review and practice questions for diabetes for this unit for your test. And I hope this helps you out a little bit, and good luck on your exam. See you next time.